Delia Munoz. So Delia, if you want to unmute and turn this over to you, we'll go through this case presentation to begin with.
Okay, so I was recently assigned this guy. He's 32 years old, homeless. He is living with his uncle, so technically he had a place to stay last week if he's still there. And he is I'm sorry, I have to reopen it again. So his medical history is just hypoglycemia for medical with severe allergies to a lot of stuff. So he says he even has to carry like an EpiPen. He does possibly have a TBI. He was severely beat, I guess, while he's out on the streets. He has a history of drug use, meth use, and he's been kind of clean for about 2 months, and I think that's when he got to his uncle's house. And let's see, he needs, well, assistance with community resources and of course housing. He's been involved, well, his uncle reports they've called the police about 8 times, so he's already had some interaction with CIT. And for interventions, he's on the wait list for New Mexico Recovery for rehab. I sent in his application to Four Winds for rehab, and he does have a CHW assigned to him. And the obstacles that are obvious to me are, there is some conflict with his uncle. He appears to, the member that I'm staffing appears to have some type of cognitive delay. The uncle says he has PTSD from the military. So there's a lot of personality clashes, like where they're both trying to talk very calmly, yet they're kind of going at each other. And the uncle was like taking everything so personally and like saying like, you know, the reason why he calls police is because he kind of corners him in the house and won't let him leave. And I think it's just because he wants him to talk to him so he can calm down. So I think that's one of the obstacles. And so he's pretty new to me, so I haven't really interacted with him. He has he does have behavioral health with Duke City Recovery and for counseling, and he has a referral for psychiatry in somewhere. I don't know if it was New Mexico Solutions. He's kind of set in his ways, so or like in what he wants, I guess I could say, because he also had a referral in for behavioral health at Presbyterian, and saw one of our psychologists a couple of times, but I think because of double billing or something, I don't know, he decided to go with Duke City. So, and then he says he's going to attend some support groups, and he wants to get medical marijuana. I forgot to put that on there. Or I guess his medication for anxiety. He does have diagnosis of PTSD, OCD, and panic disorder. Oh, he also has numbness of hands and feet. I don't know. That was another thing that he just threw in there, but there's no diagnosis for that. And I don't know. That's kind of, I kind of jumped around, but and he just has some pain, rotator cuff and back pain, I think due from injuries of being assaulted. And he's unemployed currently. His uncle says he doesn't want to apply for unemployment. I don't know why, but he thinks he would qualify if he did. And I don't know, they're looking into applying for disability. I don't know exactly how that'll go either. So it's just a little bit of everything. So that's my summary. This is kind of common as far as like, there's, of course, for housing, you know, of course, there's no answer for housing. And then just for follow-up for TBI or possible TBI.
So basically, you are the one that's trying to work with this person to get them some resources so that they can function within the community.
Yes. So I'm his care coordinator. So my job is to kind of get him into care with all his providers and community resources if he needs just would be like the rehab or housing, or if he needs referrals to providers. Sometimes I'll be the one that requests them from the provider just to kind of get that rolling to schedule those appointments.
Does anyone have any suggestions or experience anything similar to what Delia is dealing with this client? And can you give us any input as far as that goes? Dr. Katzman?
Sure. Delia, that was a great presentation. It sounds like a really super complicated case, and I can't believe you're taking care of this patient's so many kind of chronic medical conditions and kind of addiction and psychological conditions and so many kind of social determinants of health. My gosh, I'm so happy that you're presenting to share with what you're doing. It's very, very helpful. I missed at the beginning, it sounds like from the assault, he sustained kind of numerous concussive injuries and has the TBI, but I was struck by when you talked about the numbness, and I missed if you said that he also has the diagnosis of diabetes. Does he also have diabetes?
He has a diagnosis. Hypoglycemia came up in one of his charts, and I think he probably got a TBI from being assaulted.
Okay,
it's not ruled out.
Right, okay, but no like diagnosis of diabetes. And what about alcohol use?
Alcohol isn't kind of his drug of choice, so he says it's like social and it's not a problem. It was more the meth.
Thanks, Delia. This is Joanna again. So I'm just thinking about the medical problems, because so many others, I'm not an expert in anything else for sure. But in terms of the, so the hypoglycemia he's been diagnosed with, and then that he's been assaulted, so perhaps he sustained injuries that several mild traumatic brain injuries perhaps. But I'm wondering about the kind of the numbness in his arms and legs and the chronic low back pain. Has he been seen by anyone to further any of those diagnoses, Delia?
No, he hasn't. So I know I was going to work on a referral for pain management, because he doesn't, he's not on, well, he's not even, like, I think he said he takes maybe Tylenol if he has it. It's not to where he can't not complete his everyday tasks.
Okay. But, and do you know what his prior work was? I know he's not working or employed right now.
He said he worked at Pep Boys, and that was where he was at before. And then his hours got reduced, and I think he just got laid off.
Thank you, Delia. Thank you, everybody. I'm good for now. Thank you.
Thank you, Dr. Katzman. Does anybody else have anything for Delia that they'd like to share?
Hey, Delia, this is Jeff Katzman. I'm just curious, you mentioned that he's a war veteran. Do we know about that?
His dad is.
Oh, his dad is.
Mm-hmm.
I misunderstood you. Okay.
Well, his uncle. I don't know what happened to his parents. He I guess has some trauma going down to where he was like maybe 10 or something. So it's like neglect and abuse. So I don't know if that's like his only support that's left that'll take him in.
I see.
Anybody else that's not here with us in the room have anything they'd like to add? I mean, I'm not a doctor by any means, but just listening to what Delia is saying, it seems like a little bit overwhelming. This person has so many things going on, and I mean, and it looks like, or it sounds like you have some charts or something to refer to from past medical visits, but like, what do you do in a situation like this where do you try to schedule new appointments, try to get like a primary care doctor to really look at this person from a health standpoint as far as that kind of stuff goes, and then maybe a psychologist or something to address some of the other things, and then put everything together and try to find the best resource? Or how do you do that?
Yeah, that's kind of usually what happens. He has a primary care. I don't know if he had what type of insurance he had before, but in my system I only have back to February, so he might have had a different insurance. And so he does have a primary care within our system, so I kind of have access to our notes. And so, you know, I can always send her a message in our electronic in Epic, asking for referrals, like for pain management, and then let her know my concerns, like for the well, not about that, but about the numbing in his hands and feet, just in case he hasn't mentioned it to her yet. That way it comes up at their next appointment. And so luckily he got in touch already with Duke City Recovery. I know he said from the police he got a referral to New Mexico Solutions, and they might have been the one that referred to Duke City also. So they kind of followed through on some stuff, so they kind of got that started a little bit. I was just more worried. So as far as his care, he's kind of okay there. I was just kind of worried about kind of the dynamics in the home, and I foresee if he stays there, that CIT will be called more, just because the uncle really, I don't know. There was just like, I left there traumatized because there was like dogs jumping on me, and it seemed to be okay with the uncle, and it was just like too much was going on in there. And I just, you know, I think there's like a lot of misunderstandings because he doesn't see him as someone with a mental illness, and so it's like, oh, oh no, he's 36, and you know, you're just, you know, you're not getting your job, you're not, you know, just kind of like kind of the parent mentality, and he doesn't see the mental illness yet. And maybe, I don't know, maybe he thinks his care is like kind of either more important, or he doesn't see the parallel that, you know, they both have a mental illness, and he's not at the functioning as a regular, maybe 36-year-old without a history of trauma.
Well, it's good that he's got his uncle that's trying to help him out, but at the same
Mhm.
time, there's an internal conflict between the two of them that maybe neither one of them even realizes going on.
Yeah.
Looks like Sharon chatted in some stuff.
Uh,
I can read it.
Okay. All right. Sharon from Glenwood chatted in and said, there is a TBI program in New Mexico. Why does he need pain medicine?
Why does what?
Why does he need pain medicine?
He doesn't need pain. I wouldn't say he needs it. I just, you know, for pain management, I know sometimes, you know, either the primary care, or because he did have rotator cuff like pain. So, you know, I had mentioned, you know, like maybe physical therapy, or they can work out a plan for him. So that would be their primary care, or you know, referral to pain management for other pain alternatives. Medication wasn't like the thing on his list.
Right. Okay.
Mm-hmm.
That answer your question, Sharon? So she's looking at more like alternatives to deal with his pain, not necessarily saying that he needs medication to do it. Does anybody else have anything? I think I saw Joanna raise her hand.
Oh, thank you. Thanks, Captain Dunlop. And Delia, I missed if he has a primary care provider that he has a trusting relationship with. That's just one quick question. And then I just, you know, we do at UNM have both, you know, both a traumatic brain injury kind of clinic that could possibly assess him. And if he should need any kind of pain management services that the primary care provider kind of deems necessary, we could also see him from that front too, Delia. I just wanted to let you know about.
Okay. Okay, thank you. Yeah, he does have a primary care. That's who I was thinking of messaging about the numbness and stuff, just to let her know, just in case he hasn't brought it up. And but yeah, I didn't know about the TBI clinic.
Delia, this is Jeff, Catherine again. I'm not understanding also, like, is he about to become homeless because the uncle can't handle him, or what's the situation about the housing and the homelessness and the relationship and the kind of long-term ability for him to stay in this house?
So I received a referral about maybe 2 weeks ago. Well, this would be the third, and he was saying that he had like 3 days for him to get out, and then that was extended, I guess, until I went last week, and it was on Thursday and Wednesday, and then when I was there, he meant the uncle was saying again, you just have, you have 3 days to get out of here, and you can't, like, be in your car because your car doesn't work. So I think he's just kind of extending the days as we go, and that was one thing that our member was talking about, because he said, you said I could stay here as long as I was in treatment, and he's going to Duke City and counseling and that, but it is something that's, I don't think it's going to last long. And
why is that? What is it for the uncle that, he took him in, and what is it now that is making it so he can't be there anymore for a longer period of time?
I think it's just the threat that he feels, that when they get into these like little disagreements, or maybe bigger disagreements, that he feels like he restrains him in the house, and that he can't get out, which is, I witnessed one of those when I was there, and he just wanted to step away because the uncle did, and so he wanted to leave through the door, and my member was just kind of like, you don't understand me, that's not what I'm saying. And so, like, he was walking towards him, and so the uncle, like, he ended up opening one of the doors. There's 2 exits, like, in front of the house, and so I don't know if he's misreading that he wants him, like, to restrain him in the house, and he's saying, that he has to take care of himself, and that's why he doesn't want him in the house. I think he sees him as a threat.
And the meth is historic, or it's ongoing?
He's kind of early remission. He says he hasn't done meth in 2 months. I think, and that's been while he's been there at his uncle's house.
Anybody else have anything they'd like to add? We're getting kind of short on time, but close to where we need to move on to the didactic part of today's session.
Sorry, I guess I just have one more thing to add.
Okay.
You said he does have a psychiatric appointment that's coming up, or that's a referral has been made, because it seems like medication might be helpful.
Yeah, he's on the wait list for psychiatry at New Mexico Solutions. I'm not sure if they already have a new psychiatrist, but medication, I think even his PCP would kind of prescribe that, but he has it somewhere in his mind that medical marijuana would be the answer. So he's kind of not even thinking about medication.
And can he not refer to a psychiatrist in the Presbyterian network, or how does that work?
He well he was seeing one of our psychologists, and I don't know if he's one of our prescribers or not, Dr. Sanchez, and because he was seeing someone at Duke City, he declined BH through Presbyterian.
Because he just didn't want to have like 3 different providers.
Yeah, he didn't want to have, he didn't want him all over the place.
It just seems like there's a lot of behavioral stuff going on that's threatening the uncle that really could get attenuated a little bit with some medication that might make it so the uncle would be able to tolerate his being in the house a little more and him a little less threatening with if he was willing to take. I mean, there's lots of different things to think about.
This is Paige. I have one other kind of question and recommendation together rolled up into one. I'm wondering if at Duke City they have family mediation services as part of any of their behavioral health offerings, or if any of the other kind of community organizations he's interacting with might have some sort of either support group for family members that the uncle could start attending to get some resources, or if there's some option for them to do some sort of counseling or class together to work on their relationship and kind of supporting each other. Because if they really both are going through their own kind of issues, I think both of them need to be addressed, and maybe they can do that together.
Okay. Uncle said he's attended one Al-Anon, and so I think he'll end up following up with them. But I can look into Duke City to see if they have any family supports as well.
Hello,
Yes.
this is Joanna. Just very briefly, I think Duke City. I think you're referring to Duke City Toolbox, the recovery services.
Yes.
I'm pretty sure. You probably know this, but I think Paige, they do have behavioral services. I just don't know how broad they are and extensive, but they do definitely have counselors and LADAC, drug abuse counselors there. If
that's where his counselor is, and he seems to have has a good rapport with her, so he's seen her a couple of times.
Good. And the other thing is, offline, if the primary care provider, once you talk to them, if they want to refer the patient to either our TBI person, Dr. Davin Quinn, and Jeff knows him better than me, or our pain center, you can always do that, Delia.
Okay, thank you.
Thank you.
Okay, if that's all we have as far as feedback on today's case presentation, we can probably start moving on to the didactic part of this. Thank you, Delia, for bringing that to our attention. Thanks for what you do. That seems like definitely a pretty complicated case you're dealing with there. So thanks for trying to get people the help that they need. So today our didactic will be, the topic is coping with emotions, and Dr. Jeff Katzman will be leading this part of today's presentation. So I'll turn it over to him at this point.
Hey everyone, so this is like a huge topic, and so I may not give through all of this right now, and it's even really, really bigger, and that people wanted to talk some more about coping. And coping is like a lot. Coping is like coping with what? There's coping with feelings, coping with loneliness and isolation, coping with substance use, coping with all different kinds of things, with difficult relationships. So, so I'm just going to start thinking about anxiety as a way into the general land of coping. And coping in itself opens lots of different doors to think about. So that's really what I'm going to do, is try to help us think of different ways to think about coping. Maybe. Go down. Oh, here. Yeah. So as I'm saying, we have as humans an access to lots of different emotions, lots of different feelings, and we can feel angry or sad or joy or grief-stricken or guilty, or we can feel shame. We can feel anxious. We can feel fearful. In general, we're in better shape when we're experiencing our feelings. And lots of times we don't even really need to cope per se if we're actually in contact or in touch with our actual feelings. But the hard part about being human is it's not easy necessarily to get to those feelings because of various things we've been taught growing up. So this is, I've talked about before, just to review quickly. So a lot of times in lots of our families, there's lots of things going on, and for ourselves, for people we see in the field, and patients in the hospital and outpatient clinics, so that growing up, like in the first year of life, people can be overwhelmed by their child and not know how to deal really with the feelings of a baby, and so can give all kinds of signals like, stop your feeling, or your feelings overwhelming me. And so we learn to adapt. Really, the science of this is fairly remarkable, even down to neuroscience now, about how brains are shaped in the first year of life in response to actually the signals we get in that first year of life from our parents. And so we learn that feelings can be a source of difficulty. We can feel, so we can feel pain at certain times, and it may not be responded to, and that can make us angry, but then we get guilty about our own anger, and anyway, then we can even give up on the whole feeling thing, and we can detach from our feelings, from ourselves, from others, and we can develop all kinds of other self-destructive defenses, which I'll talk about sort of over sometimes in the coming weeks or months. So another way to look at that just schematically is that if we have feelings like we're sad or we're angry, a lot of times if we just have the feeling and we're in touch with it, that's not really a problem. It's the anxiety that can overwhelm us from the feeling, because like I'm angry, I don't know what to do about it, and it's making me anxious, or I'm sad and I can't have feelings because of whatever reason, and it's anxiety that feels really horrible, that can really lead us into trouble. And so we don't want to feel anxious, so we do lots of things to not feel anxious. This is just another way of showing that anxiety is like a signal that there's some kind of feeling that's coming up that's been activated, and then we don't know what to do with our anxiety, and so we develop these defenses to try to get around it. Maybe some of us think a lot, get all intellectual. Some of us kind of discharge it, and we want to kind of throw things or destroy things. And some of us might like drive really fast, and some of us might just detach completely and develop a kind of fake persona, and we're not really in touch with who we are at all, because our whole it's a way to, if we can step away from people and from connecting, it's a little bit safer. But all these defenses, they can create problems, and they're really not great ways to cope in general. They cause us problems. Yet we generally, people come in to see us because they have an over reliance on these unhealthy ways to cope, that they've developed to cope with anxiety. So like I'm saying, sometimes things we do to cope with anxiety and being anxious, is to kind of get it out of us. Like maybe we'll use substances to kind of make the feeling go away. People talk about self-medicating, right? Maybe we'll yell and throw things. Maybe we'll drive fast. Maybe we'll do anything excessively. And maybe we'll eat. Maybe we'll gamble. Maybe we'll do lots and lots of things to distract us from the actual internal sense of anxiety that can feel so bad. Or we can do something against ourselves, actually, to make the anxiety go away. So people will cut, right? And they say, I just wanted to feel myself. I want to feel something. But a lot of times that can, for people, be a way to discharge anxiety, or we can withdraw, or some people can just restrict lots of things. People can stop eating. They can just generally be more perfectionistic, and that's another way to kind of minimize anxiety by kind of detaching and minimizing the anxiety this way. So I'm not a big, personally, I might get in trouble for saying this, I'm not a big personal fan of like wellness programs, because it always feels just like another pressure to me, another thing I have to do in my life, and another set of meetings, and another thing I'm going to be assessed about now, like how well am I? But it's really a big deal. It's a big deal in medicine right now, major organizations, and we're all assessed now about our wellness. Even programs are accredited by how well their employees are. I mean, there's lots of kind of things to think about that wellness programs always talk about that to me always make me more anxious because it feels like another pressure, another thing I've got to deal with, and people don't give me time to go do these things. But here they are, and they're all really helpful. So we should talk about them as just general ways that we can all, and our patients and people can actually start to minimize the sense of anxiety. And we know that if we exercise regularly, particularly if you can do aerobic exercise, and studies have shown even if you can get to like 150 minutes a week, that's very, very helpful. That's even helpful for potentially preventing cognitive decline. If you get regular sleep, though, like I'll talk about, that just makes me more anxious because that's another thing I have to do then is fall asleep. So these are really pressures, but definitely if we get enough sleep, we know that we feel better, and our anxiety can sometimes come from not getting enough sleep. Yoga and getting into our body can really, really be helpful for anxiety. And meditation can be, of course, extremely helpful. Making lists and schedules can really help to actually find a way to contain things. So I can feel maybe free-flowing anxiety, but if I can make a list of tasks and things that need to get done, then I can feel like I'm managing it. I can feel less out of control. I've mentioned this before, but if you can get to nature, and the studies show especially to water, and there's even a study looking at bathtubs, I'm looking at water in a bathtub, that actually that's extremely helpful to deal with an experience of anxiety. To me, the most important thing is to find meaning. And a lot of times we get anxious because we're doing lots of things that seem meaningless. And that can be really overwhelming. So to find something that has meaning in our lives is very important, especially with what all we do in the system that we work in. When we feel overwhelmed that we're not making a difference, then we have to start to focus a little bit on what does make a difference. And then the most important thing is to not listen to anybody else tell you about what helps with anxiety, like someone like me, but actually know yourself and figure out what helps you. I mean, one patient told me that the thing that helped him the most was every night getting into a bath with a big tub of popcorn and lying there and taking care of himself this way. So what I'm saying is we all have it might be watching television, it might be lots of different things in moderation that actually help us to calm down, and they may not appear, some of these things, on a list that a wellness program gives you, or that you can find on the internet, because they actually have to come with you, because our anxiety is highly personal and has to do with our own sense of what's going on. And then, of course, talking about our feelings with somebody and our anxiety really can help us to feel calmer as well. So there are some kinds of behavioral therapies that can be helpful to calm down, that are helpful to learn. I won't spend a lot of time with them right now, though we can in some way. There's specific kind of types of things that people can do quickly. So there's ways of breathing where you're holding one nostril at a time and taking breaths in and out that has been shown to be helpful with anxiety. There's Andrew Weil has something called the 4-7-8 format of breathing, where you breathe in with a count of 4, you hold for a count of 7, and you breathe out with a count of 8. That's also very helpful with breathing. Mindfulness meditation, where we actually focus and become more present in the moment, is very helpful. Visualization and focusing our mind on our breath is very helpful. Guided imagery, where we actually can imagine a place, such as a meadow, or there's all different kind of scenes that people who do imagery regularly will talk about. Progressive muscle relaxation is another one, where we start with the feet and squeeze your toes as hard as you can and do this kind of all up our body. And then I must really give a call out to the various apps that are on our cell phones, because they're only, most of them, 5 minutes long. So like Calm and Simple Habit, and there's lots of other ones. Simple Habit has, I think, over 100,000 different apps 100,000 different tapes that are like guided imagery along different themes, but they're each only 5 minutes long. So they're for sleep, they're for anxiety, they're for confidence, they're for all different kinds of things. And you can kind of find somebody's voice who you like and that's a match with you, and it can be a very helpful thing, even to just take that 5 minutes in the middle of the day for people can be extremely helpful. We also, it can be very helpful to track the thoughts and start to understand what triggers our anxiety and wonder about those triggers, and are we exposed a lot to those triggers, and to start understanding it, because sometimes what anxiety really is a physiologic experience that overwhelms our ability to think, and what we have to do is start thinking about it. And to provide a structure for our anxiety, to start actually tracking what are the things that are triggering my anxiety is really helpful, and also to notice the environmental triggers that trigger anxiety. Like, is it travel? Is it transitions? Is it certain situations at work? I should have written this down, but it can also be particular relationships. Particular people can really stress us out. I don't know if anybody has had that experience or not, but most of us do. And you can actually start to notice that, and you can actually start to shift your relationships a little bit based on those relationships that are supportive and those that actually are highly stressful. And then you want to notice things that you do, that we all do, that can make us anxious. When we take on too much, we care about too much, others a little, too much at the exclusion of taking care of ourself. And we want to notice patterns within our close relationships that can lead to our anxiety, or that we can make other people anxious. It is very helpful when you're overwhelmed, particularly for any kind of extended period of time, to talk to a therapist who will offer support. That in and of itself, the evidence is very high that just a supportive therapeutic relationship without any specific technique is extremely helpful and can help with anxiety quite a bit. Though some kinds of therapy will offer specific techniques like CBT or down below that's cognitive behavioral therapy, or dialectic behavioral therapy, that's DBT, or mindfulness, or mentalizing, or acceptance and commitment treatment. These are all interventions that are evidence-based ways to actually help with anxiety. And then some therapists will help us to understand how early patterns, like I was talking about before, patterned our mind and are actually being replayed in our life, and try to help us understand those and see those, so that we can actually have get to the feelings that we weren't able to feel before that are making us anxious. That's a lot I just said in that sentence. I could say some more about it. And then there are medications that are really helpful with anxiety. We probably all know these, but the benzodiazepines are highly helpful for anxieties and highly problematic because of their addiction potential. My pharmacology instructor from UCLA and during residency, Mike Gitlin, used to talk about benzodiazepines being like a religion, and that people have real fervor about them, very strong feelings. They lead to all kinds of problems with therapeutic alliance with doctors who feel okay about prescribing them or don't. And then there are the SSRIs and SNRIs. All are helpful with anxiety in a longer term model. There they all are listed there. And then other agents that can give us a sense of calm. Buspar or gabapentin can help us feel a little calmer without the problems of addiction that the benzodiazepines create. A big thing about anxiety that's so important, like I said, is to get sleep. And that's in and of itself often not so easy to fall asleep or to stay asleep. So we think about various things that have been shown to be helpful about sleep. So we want to, just to review those things, going to bed at a regular time is very helpful because our body starts to learn this is time to go to bed. We want to go to sleep when we're sleepy in general. So we want our body to develop a body rhythm at which this is the time at which we get sleepy. If we're not falling asleep, we want to get up. We want to go somewhere to another room, read a boring book, is what people talk about, and then try again. avoid caffeine and nicotine, particularly caffeine at night, or for some people it's any sip of caffeine. Some people will notice after 12 noon. Dr. Christensen talked about how alcohol can really mess with our sleep structure and the quality of sleep, and so people can be tempted to drink to help them fall asleep, but actually then they can actually wake up more often in the middle of the night. Also, the general idea is that the bed is for sleeping. It's not for anything but sleeping, so that we start our brain associating the two. It's not for like looking at our cell phone or watching television or those things. So lots of people can do that when you're working on sleep. It's important to kind of start to associate bed and sleeping. And important, if you're not getting enough sleep, to try to get the sleep all at night. So naps mess with us. So we don't want to get too involved with, we don't want to take naps, even if we can avoid it. Naps can be very restorative, but if we're not getting enough sleep, we can try to minimize the naps so that we can start to get better sleep at night. And really, these days especially, not so easy to do, but it's really important to kind of unplug 90 minutes before sleep and not to go online, not to look at our cell phones, because our brains need to calm down. We need to not see certain frequency of light, and we need to not move our mind with a certain degree of rapidity that lots of people go look at their cell phone and then try to get right to sleep, but the mind keeps going. It's helpful to have like rituals to go to sleep. Certain things that we do regularly, taking a bath, warm water is very helpful. Getting rid of any clock in the room and not looking at a clock is helpful. For a couple of weeks, if you're having trouble, you can keep a diary and start to see what is the pattern of sleep, what keeps you, those kinds of things. Exercise is very helpful for sleep, but not later in the day if that is associated with poor sleep. Eating right, people talk about various things that can, a diet and how that can affect sleep. You want to sleep in the right place where there's not a lot of noise. Cooler temperatures are associated with better sleep, particularly with blankets and weighted blankets. And you want to have a daytime routine that's generally the same too, because having to move from thing to thing to thing and lots of different activities can also get your mind really activated in the night. And we know these two, melatonin is generally the thing that helps a lot of people fall asleep when they're having trouble. Hydroxyzine, Benadryl are also relatively safe medications. The benzodiazepines are useful in low doses and temporarily. They create a lot of potential for addiction, as well as feelings from prescribers in general. People don't want to wind up taking benzodiazepines for long periods of time. Trazodone, mirtazapine, Elavil, and doxepin are all antidepressants that are sedating, that are used to help people sleep. It's also not helpful to have like a fight with your significant other right before you're going to go to bed. And inevitably that's what happens. But a lot of people are up late because of what goes on within their relationship with the person that they're sharing the bed with sometimes. So then it's difficult to sleep. So if we think about couples just in general, there are various issues to think about that can contribute to anxiety that couples go through, depending on where they are in their relationship, whether they're courting and those kind of issues that keep people make people anxious about whether this will work or whether it won't. That we're from different backgrounds, pulls from our family of origin and having to take care of somebody like a mom or a dad or a sibling can really keep us up at night and make us anxious during the day. I have down there sandwich generation issues. That's like there are things going on from our parents sometimes, and as well as needing to take care of our kids, so it can feel like you're just in the middle having to kind of take care of both ends, and it can really be an overwhelming experience for lots of people. And more and more and more that happens now as people are living longer, and people are winding out of having to take care of parents and children simultaneously in some way. There are issues in the beginnings of a marriage, when kids are involved, when kids leave, when people retire, when they have medical illnesses. These are all different things that contribute to anxiety within relationships. And couples go through all kinds of things that they're trying to figure out, like who's going to stay home or who's working if both people can't, if someone needs to take care of the kids, and a lack of understanding of the world of the other person, and roles and resentments that people get into, and triangulation with their children, so that somebody's closer with one kid, and then that's not something that's flexible or looked at or played with, but becomes the rigid rule for people, can lead to really some resentment. Like I said, pulls from family of origin, or psychological pulls, like we call them ghosts from the nursery, like this is the way my mom would have wanted me to do it, or unconsciously, and so this is how I'm going to raise my child, for example. And the stresses within a relationship of illness and trauma, or disagreements about how to live a life. All those can really be very, of course, powerful issues for couples, especially if you don't know how to work them out. So how do people negotiate these things? And then in a few minutes, I'll just say that there's kind of a doctrine of what's fair when people are having a fight, in order to actually come together and get more deeply connected, as opposed to just to hurting each other. And that is, in general, here's the canon, in general, and in our relationships when we're fighting, particularly if you're not a skilled couples negotiator. When you're really like a black belt at this, you can maybe have more than one problem at a time. But really, particularly in the beginning, when you're trying to get through things, you want to stay with talking about one problem at a time. We're talking about who makes, or where we're going to go for dinner, or why I always have to do something and you don't. You want to stay with that problem, because people can't easily solve multiple problems at a time. You want to fight in general in a safe place where there's time, so probably not generally in a restaurant with lots of people around, or as you're walking out the door to your days. It has to be safe to separate. So if somebody's feeling overwhelmed by their anxiety and their feelings, needs to be okay for someone to leave. We need to make statements about our experience. So like, I'm feeling hurt by what you're doing, not you're such a jerk or something like that. Those are two different things. We want to really talk about what I'm feeling, so that the other person can enter our inner world, as opposed to just labeling, which makes another person defensive. We don't want to use the words always or never, like you always do this or you never do this, because those are never true, and they only make the person we're with search for reasons that they're not true, get defensive. And then in general, when we want to try to repeat back what our partner is feeling, so they know that we get it. And that's how you can start. If we get each other's internal world, that's really the beginning of resolving difficult situations. So there you are. There's coping. Yeah. So thoughts or questions?
Thank you, Dr. Katzman. Does anybody who's not here with us in the room have any thoughts or questions they'd like to add to Dr. Katzman's didactic on coping with emotions? Nobody? Okay. Anybody here in the room?
This is Delia. I have a that was a good presentation. I have a question about I like dealing with parents who don't understand anxiety. Like, how to explain that? I don't know, maybe it wasn't like something that was super high like back in our time or our parents' time, but just how to make it real and understandable, because I know this is a problem with our kiddos too, where they don't feel understood by their parents. And so I just have to see if you guys have a recommendation with that.
Yeah, like so when I'm doing like family work in the psychiatric emergency room, I see that quite a bit where kids are coming in because they've run away or they're mad or they bit their brother or whatever has happened, and that's because they feel like nobody's understanding them. And sometimes if to understand like an emotion or something is not um, so easy, but I think when a child is able, like with their parents there to actually say what's going on, just even having the parents say their words back to them without getting defensive or without telling the kid that they're wrong, but just being able to say, okay, so you're experiencing this or you're feeling this, can at least start getting people on the same team rather than perpetuating this idea of misunderstanding. So that's kind of first thing I would say about that is more than understanding of like what someone, a particular feeling, it's just can a parent begin to reflect actually what their kid is experiencing without the judgments and statements that the child is incorrect or lying or selfish or whatever they might think, so that they can actually get to the other person's state of mind. Yeah, so that's part of what you would call like reflective functioning. Can somebody actually get what's going on in the other person's world as well as in their own?
Jessica chatted in. Thank you.
Sure. And then it looks like we got a chat from Jessica. She lost her audio, but she has a question. She says, setting boundaries helped alleviate my anxiety in a major way at work and personally. This can be a hurtful process. Any advice on how to do this gently?
Yeah, so we could probably spend Jessica another hour talking about that at least. I think always like context is helpful. So when we're setting boundaries, sometimes it's helpful to tell people we're not setting a boundary with them, but around a task. So it's not that I don't want to spend a lot of time with you and do everything you're telling me to do, but there's actually a limit to the number of hours I have in the day, and so I can only do these things. Or I really enjoy talking to you, but I don't think you're right match for this particular kind of position. So like I just sometimes it's really context or even sharing the whole complexity of our inner world. So it's not just saying no, but it's like I wish I could. I wish I could do all that, but I really do because that's so important. But I just can't right now, or I won't be able to function effectively in these other places. So I think sharing kind of sometimes the reality of the situation makes things a little bit less hurtful. Like I wish I could work with you more, but I'm just be your supervisor or whatever it is. But there's just I'm being stretched so thin right now. I won't be effective at it. I don't know if that's helpful at all.
Does anybody else have anything they'd like to add?
And Jessica, I think that's a great thing too. Like, as we don't really have anyone protecting ourselves other than ourselves most of the time. So being able to actually value ourselves enough to say, like, I can't take this on, and there has to be some gateway here of that's guarding what I can take on. Realistically, is a really important way to actually take care of ourselves and increase our anxiety.
I have a
Dr.
question. I just
Joanne?
have one comment.
Go ahead, Dr. Katzman.
Oh, sure. I just have one comment, and I think, Jeff, you might have mentioned this as first. I think as like first responders and clinicians, you know, people in the healthcare community already have such a hard time, you know, taking care of taking care of oneself. And then I think first responders in general are just constantly, and this goes for clinicians and physicians and any type of healthcare provider also. We're at the, you know, we went into the profession because we wanted to take care of everybody else. And so it's like in our nature already to kind of, you know, put ourselves down on that to-do list, you know, is like number 10. And so, and I think first responders, even more, I would say, than physicians, are even more inclined go to that emergency to help somebody else. So I think that it's almost more important to kind of, you know, to give for first responders and healthcare providers to, you know, to know it's okay to give yourself a break. Does that make sense? You know, I think it's harder than for other professions. Over.
Yeah, that seems right on.
I just wanted to say too that for me, oftentimes when I hear something really interesting from these sessions, which is often, I won't have time to take notes, or I would like to be able to refer to the notes, and we're now putting them on the website so that if you want to refer to the lists that Dr. Katzman showed us today, you can do that. I know I will be doing that. There are a couple of really good lists there.
I'd say also too that this is Jeff again. To the boundaries question, like I think it is really pretty stressful for all of us to be working in a system that's overwhelming with not enough resources, feeling like we want to help. And I think there is a boundary to that, like a personal boundary of I'm doing what I can do, but I can't save the system. I can only do my part of it, which is just something we all kind of wrestle with. Also, what can I do to make this better without getting lost in my own feelings about all the things that should be here that are not.
Okay, well, does anybody have any closing words? We're a little bit past the end of the time for this session. To Delia and Dr. Katzman, thank you both for your case presentation, and Dr. Katzman for the didactic today. There's a ton of great information on both of those. For everyone who joined us today from somewhere else, thank you. We had a larger than normal presence on the screen, which is awesome to see. We're glad you all were able to take some time out of your day and listen to what's going on here and work together. Just to let everybody know, we're going to start changing these sessions. They're not going to be weekly. They're going to be every second and fourth Monday from 2 to 3:30 p.m. So our next session will be Monday, March the 9th at 2 o'clock. And I know that we should have an actual didactic for that session, and it's going to be on child abuse, and someone from the Special Victims Unit from the Sheriff's Office will be doing that. So I guess try to put out a little challenge to all of you who joined us from somewhere else. We need a case presentation from somebody for that day. So if any of you would like to get together with us and discuss a case, and maybe some of the people that are signing in from somewhere else, or somebody in the room, and all the different areas of expertise we had can chime in and maybe help somebody solve something they're having difficulty with. So let us know if you can do that. You can contact, go through the website, and Karina can get you set up with whatever you need, if forms or whatever you need to do that. And if you haven't done a case presentation, they're really simple to do. The form walks you through the process, and basically you just go over, what you experienced in a certain situation, and then everyone else will kind of listen to what you have to say and see if there's if they've experienced something similar, and how we can help you or make the situation better if you come into it again. So that's all we have for today. Thank you all for joining us, and we will see you on March the 9th at 2 o'clock. Have a good day.
Thank you.
Thank you. Thanks, everybody.
Thank you.
Leave it open.